In this PowerPoint, we're going to be talking about how to interpret the initial evaluation. This is actually something you guys have already been doing in quarters 1 and quarters 2 with your lab practicals when you're presented with some information and then you needed to come up with a treatment based on that information. Today we're going to go into that a little bit further as very soon you guys are going to be putting bigger treatments all together, kind of like you did at the end of the last quarter, combining therapeutic exercise and modalities. So you can read through these objectives, but basically this is going to give you information on where you can find things in the initial evaluation and then what types of questions to ask, where to look in the evaluation to make a clinical decision as to what intervention you're going to provide and how you're going to provide it. So we'll be going over each component of the SOAP initial evaluation note. That includes the problem, the subjective section, the objective section, the assessment, and the plan, how to use that, and any other questions you might need to ask before coming up with the way to treat that patient. I do want you to note that some of this information will be included in the SOAP notes that you write, but it is definitely a lot more information in the initial evaluation than what there is in the daily notes. So I'll briefly go over the continuum of documentation in a physical therapy encounter. You have the initial evaluation, the interim notes, which includes the visit, and the encounter notes. We have the daily notes or treatment notes, and then also the progress notes we'll talk about a little bit more. It details the interventions provided, and it talks about the patient's status and progress. The PT does the documentation for the re-examinations or the re-evaluations, and then the discharge summary is at the end of the episode of physical therapy. Okay, I feel like this is getting drilled into your heads, but the roles and responsibilities of the PT versus the PTA. So the PT does the initial evaluation, the progress notes, the visit or the encounter notes, the reevaluation or reexamination, and the discharge summary. The physical therapist assistant does the visit or encounter notes, and then I have a little asterisk after the progress notes. So I already talked about this a little bit in class, but I'm going to touch on it again here. So progress notes are summaries of care, and they're showing the progress of routine usual treatment and outcomes. If there's not a routine usual outcome that you'd expect, that's when you're getting your PT involved. So I'm talking about a routine course of physical therapy that follows the way that it should. So I just want you guys to know that in the book it says it should be done by a PT. So I agree with that to a point. It is when it is required by state law or the third-party payers, and they do that to ensure that the PT is maintaining the patient care responsibility and meeting all legal and ethical expectations. You will find that there are PTs that just turn a patient over to a PTA and then never check in on them again. That is not legal, and nor is it ethical, and I wouldn't want to be a PTA working under that PT. Hopefully there's a good line of communication where you guys are working together to get that patient better. So if you remember from class, it is not against the law in Medicare Part A or most regular insurances. That's your Blue Cross Blue Shield. UHC is another one that comes to mind, though recall my time in the clinic, UHC can get kind of sticky on some things. But whether or not you do a progress note is going to vary by the facility and then also by the state. I don't see anything in our Practice Act that says PTAs cannot do a progress note, but if that progress note includes some evaluation features, that is when you have to make sure the PT is involved. Or you can have the PT co-signing their note to show that they took part in the evaluation of the results of your progress note. On this slide and on the following slide, you're going to see a repeat of the information about what can be found in the initial evaluation. We're going to go over it very briefly so you know where to look when you're gathering your information for the treatment you plan on completing with your patient. Also, in the initial evaluation, you're going to see the tests and measures that the PT did, and those are going to be tests and measures that you're going to be repeating in your interim or daily notes are in your treatment of the patient, so we can show if they are progressing. So the documentation of a patient's episode begins with the initial evaluation note. It should provide a clear picture of the patient, and it documents the PT's professional judgment. They give the diagnosis, that's physical therapy diagnosis, the prognosis, and their anticipated goals. And then it also includes that plan of care, which, as you guys recall, a PTA has to work within the PT's plan of care. The initial eval will use as a reference for patient contact, and it provides a framework. I, as a PRN therapist now, since I'm out of the clinic, I will still look at the initial evaluations when I'm seeing somebody else's patient because I don't know anything about them. And there will be things that I look at kind of quickly, and I know where to go to help me come up with the treatment that I'm going to do for that patient kind of quickly and that day. And that is where you guys are going to be going to help come up with your treatment. So here's a list of all the things that could be included in the problem, the patient's chief complaint, their medical diagnosis, and any contraindications, precautions. For an example of that, medical diagnosis could be right total hip ORIF. Contraindications, precautions could be toe touch weight bearing on the right lower extremity. Another medical diagnosis could be right total hip arthroplasty. And again, a contraindication would be hip precautions. So a PT might also put in the contraindications or precautions. Things that you want to know is if the patient is impulsive, or if they're at a fall risk, or if they have any cognitive deficits. You guys might be able to find those things right there to give you a better idea of the patient. You'll also see the physical therapy diagnosis, the referral for the PT services, what doctor, nurse practitioner, PA, etc. that it is from, their functional limitations, and then you might also see some information from their medical records. This slide is a really good example of a problem. It's giving you a lot of information that was talked about on the next page. The evaluations that you look at may or may not have this information, but as you see here, you're kind of getting an idea of the person. You know that they have MS, and you know that they have balance and coordination deficits. So the wheels should start turning in your head as to what things you might be doing with this patient just by looking at this part of the initial eval. These are the things you're going to find in the subjective section of an initial evaluation: the patient's current medical history, their past medical history, their symptoms, the things that cause the symptoms. You guys did this a little bit on WILDA, what aggravates their symptoms, what makes them feel better, the patient's prior level of function, their lifestyle, occupational, societal roles. That's where we can get some of their participation restrictions, and also, importantly, the patient's goal for therapy. The next two slides have a good example of a subjective section of the initial evaluation, and that is a very good example. There's a lot of information there that is good that you can use, again, in deciding on what treatments to do and how to do them. The objective section has the tests and measures and also observation by the PT for the initial evaluation, the interventions that the PT provided during that treatment, the patient's response to those interventions, and then also the patient education that the PT provided. And here's where you'll look and you'll find what test and measures the PT used, because you will be likely repeating those in your treatment sessions. The next two slides show an example of the objective portion of initial evaluation. On this slide are the systems review, and on the next slide are things you've probably been more familiar with: the manual muscle testing, range of motion, posture, functional mobility, that type of thing. Okay, the third part of the SOAP note, the assessment, and again, this is part of the initial evaluation. So you're going to see the PT's interpretation of the S&O data. This is also where they say this is a PT's role, where they do the evaluation of the data and then they make clinical decisions based on it. The PT should have their goals. an identification of their impairments and limitations, the physical therapy diagnosis, the prognosis and rehab potential, their justification of the goals and treatment plan. If they did have any problems obtaining the S&O data, they would explain it here, and any recommendations for further testing, treatment, or referrals. I worked at Tabitha a few weeks ago, and I had a patient who was very agitated and did not cooperate with the initial evaluation. I was only able to get her to stand up in the parallel bars and then do some gross testing of her range of motion and her strength. So I did the evaluation based on the information that I had. I did have to explain it in the assessment portion of the note, and one of my recommendations as a result of that and her agitated state and how it was hard to get her focusing, I suggested that a speech therapy evaluation would be warranted to get an idea of her cognitive status, because that was definitely having a bearing on her ability to participate in physical therapy. And on this slide, you see an example of the assessment. You see how the PT kind of brings everything together, the information that they picked up from the subjective and objective. You can see that they bring in the ICF. In the second sentence, the patient is unable to maintain her current employment and is not able to meet her roles as a wife and mother. So her societal roles are as a worker and also as a wife and a mother. And they also talked about the patient's rehab potential and things that could be affecting therapy, and how that might also affect her ability to meet her goals.